Welcome back to Science of Medicine. Today I want to talk about diagnosing disease and using various tests in that process. So first thing you need to understand is what a disease is. Now if I look at a collection of people, there will be a normal variation in various things that I could measure about the person, such as their temperature or if I did blood work. And that diversity of normal is simply normal variation. But a disease has a particular etiology or cause that changes that normal. And that normal structure then can be dysfunctional when it is outside of very specific ranges. And depends on what these are as to what the disease is. Now, an illness is when a person feels distress as a result of that disease. It could be that I feel sick because I have an upper respiratory infection due to some viral pathogen. Or it could be that I feel ill because of my body's attempt to fight off some sort of infection or pathogen. Now, within the nature of disease, we can think about it in terms of being a genetic or intrinsic disease. For example, for Caucasians, cystic fibrosis is very common. This inherited condition leads to a loss of function, which causes the disease. And there's a specific deletion on a particular chromosome that leads to a defect in a certain transporter folding properly, and that leads to problems with chloride ion channels, and eventually then leads to thick mucus in my lungs, as well as problems with my digestive tract from my pancreas. So there are a series of genetic diseases that are known within humans. There are also acquired diseases. These could be from a pathogen such as Mycobacterium tuberculosis that causes tuberculosis. It could be my body attacking inappropriately itself, autoimmune diseases such as type 1 diabetes, mellitus, or, for example, rheumatoid arthritis. It can be related to nutritional if I don't have the proper building blocks for my body to function, for example, iron, and that will lead to an iron deficiency anemia. I can have damage either chemically from, let's say, ethanol hurting my liver, or UV radiation leading to skin cancer. So whether I have an intrinsic or genetic disease or it's been acquired, these are the nature of our diseases. Now, one of the challenges in terms of being a physician is to distinguish healthy people from those with disease. And there are several considerations when a person comes in and wants your advice. The first is that don't hurt the person. That is the basis for medicine. I don't want to do something which is likely going to harm you. So for example, if you come in to an office and you have a cough, no one is going to do a bronchoscopy by sticking you on a ventilator and then going down into your lungs and washing it out. That would not be an appropriate first step. You also want to avoid a serious disorder. And those are disorders that could irrevocably either cause harm that you could have avoided, or it could be causing death. And in doing this, physicians really use Bayes' theorem, which I talked about initially in this course. So remember, Bayes' theorem was a mathematical way of telling us how the relative probabilities of something are based on pertinent positives and negatives. For example, if somebody comes into an outpatient office with a complaint of cough, there are several common causes of cough, such as postnasal drip or asthma. Infection is one of them, acid reflux another one. But if that same person came into the same clinic and said, I have a cough, but I have fever, you do a blood test, and the white blood cells, which are used as an indication of whether you're fighting off a bacterial infection, are elevated, and I do a chest x-ray and that chest x-ray shows an opacity or a whiteness on it, then the chance that you have an infection is much higher than that cough is being caused by, let's say, acid reflux. Now remember, science is falsifiable. That means I can never know the right answer, but I can understand when additional information is going to be useful in helping me make decisions. And then also how to interpret the result of those tests in light of that additional information. And that's what I want to talk about today. So, first off, let's talk about the measurements that you could make. So, whenever a person makes a measurement, it could be a direct measure of what I'm trying to look for, a disease, or an indirect measure. And direct measures are generally more reliable than indirect measures. I also will make measurements, and sometimes I'm interested in the actual value, and other times I'm just interested in if that value lies above a certain threshold. So let's talk about some direct measures. As I mentioned, this is the more reliable evidence. And so, for example, if I wanted to look for cystic fibrosis, I could test for the particular genetic abnormalities that can cause cystic fibrosis, giving me a genetic piece of evidence that the person would have cystic fibrosis. Or, for example, if I took a culture from a wound or from sputum or some other place that I believed to have a bacterial infection, and I put it onto a growth plate and then allowed that bacterium to grow, I could identify that bacterium, and that would be a direct measure, assuming I didn't contaminate that sample. But sometimes I don't have direct measures, or they're very difficult to do, and so I have to rely on indirect pieces of evidence. And so an indirect piece of evidence might be that I have some sort of inflammatory response, and a C-reactive protein or an ESR, both of which can be increased in inflammatory conditions, might be elevated. Doesn't tell me what's causing it, just tells me that it's present. Or, for example, if I measure in a blood test that the amount of alanine aminotransferase, a liver enzyme, is elevated, it could be because there's damage to the hepatocytes of the liver cells. I could do a PPD, a purified protein derivative test, by taking a small amount of this tuberculous material and placing it just underneath my skin and then looking for a reaction to that. That's an indirect measure that I've been exposed to tuberculosis. Now, as I mentioned before, when you have a normal range of values, for example, blood glucose in a person who is not diabetic, normally will range between 70 and 100 milligrams per deciliter if they're fasting. And if they're not, it might go up to about 140 milligrams per deciliter. So anywhere in that is really considered to be normal. But then if it's abnormal, it might lie out of that range. For example, I've seen blood glucose readings that are down as low as 20 milligrams per deciliter, and I've seen them above 2,000 milligrams per deciliter. So humans can have an enormous range of values. Only a portion of those might actually be in a normal range. Sometimes we only care about a threshold value. For example, beta HCG, which is released when a woman might be pregnant. There are other reasons that it might also be present, but that's the typical one that's used. So if a woman thinks that she might be pregnant because she is late on her menstrual cycle, she can test with a small type of assay where she would maybe urinate onto a strip, and that strip above a certain cutoff level for that beta HCG would indicate that pregnancy is possible. Now, all these tests that I have as a physician at my call have characteristics that help the physician decide whether that test result is of potential use. Because you don't run tests just because you can run tests. Number one, they can potentially harm the patient. Number two, they cost money. And number three, they may not help you and they may even confuse matters. So when you're trying to decide whether to use a test or not, some of the characteristics of that test help you in that decision. And the two most important ones that we'll talk about today are medical sensitivity and medical specificity. So if I think in a very black and white type world, I either have a disease or I don't have a disease. It's either present or it's absent. And I could think about a test result either being positive or negative. Now, this is a bit of a stretch. I might have a disease but not be able to actually know that that disease is present at that moment. I might have a test result that might be somewhat ambiguous, and so it's not clear whether it's positive or negative. But for this purpose, I'm going to look at just this bipartite kind of view. The disease is present, it's absent, the test result is positive, or it's negative. And I've done a little 2x2 square that shows you there are four possibilities. If the disease is present and the test result is present, that's what I want. And so test is positive, disease is present, that's a true positive. Likewise, if the disease is absent and the test result is negative, true negative. That ideally is what I would like, but all tests don't do that. I can have a test result being positive when I don't have the disease. That's a false positive result. And I can have a negative result when the disease is actually present. That's a false negative. So we define medical sensitivity as the true positives over the total number of people with disease, and the medical specificity as the true negatives over the number of people without the disease. Another way of sort of looking at that is that a highly sensitive test means it's detecting the disease, and it has a relatively low number of false negatives. Therefore, if you have a negative result, it pretty much rules out the disease because there are a low number of false negatives. A highly specific test is going to detect those who don't have disease and have a relatively low number of false positives. So if I have a specific test, a positive result rules that disease in because it's very unlikely that I have a false positive. It's probably going to be a true positive. So medical sensitivity, medical specificity, characteristics of medical testing, and this is an important consideration when you're actually making your determinations of what test to order. One other characteristic that people will sometimes use is a positive and negative predictive value. So a positive predictive value says I get a positive result for the test. How likely is it that that's true? And a negative predictive value is how likely, if I get a negative test result, that the person really doesn't have the disease. So I can define them as I've shown up here, positive predictive value over true positives plus the total number of positives versus the negative predictive value, the true negatives over the total number of negatives. It's easiest to see how this works by doing a problem. So I'm going to talk about a 38-year-old woman who goes to your clinic after she's had a digital screening mammogram. Now, normally we do not do screening mammograms on women of average risk in their 30s. But let's say for some reason that she went out and had this done. Now, if I look at women in general, there's about a 1 out of 8 chance that in the lifetime of that woman that she will have breast cancer. She'll develop that. It may not be when she's 38, maybe when she's 68, but there's about a 1 out of 8 chance that she'll develop that. But in the age group of 30 to 39, breast cancer is rare, about 0.5%. Now, if I look at different screening modalities, Digital mammography is one of those. And let's say that that sensitivity, the ability of that digital mammogram to detect if the person has disease, is 85%. And let's say that the specificity, that is to detect those people who don't have breast cancer, is 90%. So I'm going to use those. How do I actually figure out what this test result means? So she comes to your office, she says, I have a breast mass, and the mammogram says that there's this breast mass. Do I have breast cancer or do I not? What do you do to make sense out of that for her? So one way that you can do this is to use that characteristic sensitivity and specificity of the mammogram to help frame this in a quantitative fashion. So if I look at a population of women in their 30s, I'm going to pick an arbitrary number, 100,000. You could choose 55, but then you'll be dealing with fractions of people and stuff like that when you do your calculations. So for my pea brain, I like to do this in just factors of 10. So 100,000 people. And of those, I would expect in their 30s that 500 of those women, 0.5%, I told you is incidence of breast cancer for women in their 30s, 500 of those 100,000 women are going to have breast cancer somewhere along in there. And 99,500 of the women are not going to have breast cancer. Now, of those with breast cancer, 425, 85%, that's my medical sensitivity, 85% of them are going to test positive, truly positive. So that's 425 or 85% of 500. And 75 are going to test negative. Those are going to be false negatives. And of those patients without breast cancer, 90% of the 99,500 are going to test negative, truly. They're not going to have breast cancer and they're not going to have, then they're going to have a negative result. But 9,950 are going to test positive, but it's going to be a false positive. So I'm going to show that a little graphically. My 100,000 women, 500 of them with cancer, 99,500 without. Of those with the 500 with cancer, 425 are truly positive, 75 are falsely negative, and of those people without cancer, I'm going to have 9,950 false positive mammogram results and 89,550 true negative mammograms. So I'll do my little 2x2 table that I told you about before, where the true positives, 425, the true negatives, 89,550, and then the false positives and false negatives. Now I can calculate a positive predictive value. The patient said that she had a breast mass on that digital mammogram. So I can calculate that by taking that true positives, 425, over the total number of positives. And that's not only the true positives, but the false positives, which are very high. And so when I calculate that positive predictive value, that turns out to be 4%. So how do I interpret this result? Well, if she hadn't had a mammogram, you would expect that she would have a 0.5% chance of having breast cancer. It'd be the average risk across somebody in their 30s. And with this positive mammogram, it's increased her chances almost tenfold to 4%. But it's much, much more likely that she doesn't have breast cancer, and the result was a false positive. There's a 96% chance that she doesn't have this. So when a physician considers whether or not to order a test, he or she really has to think about, how's this going to help me? Is this going to assist in making a decision for diagnosis or not? Let's give a more typical kind of example. People have influenza. Let's say that the influenza time is in the winter time and it sort of peaks, let's say, in January. Somebody comes into your office in October, and the prevalence of flu is low at that time, about 2.5%. Now you can use one of many different rapid flu tests. I gave you data right here for medical sensitivity and specificity for the QuickView influenza A and B test. And so you perform that test and you have a positive result. How do you interpret this? So I'm going to go back. I'm going to consider some arbitrary number of people, call it 10,000. If the prevalence is 2.5%, 250 will have flu, 9750 will not have flu. I can use the medical sensitivity, 73%, and specificity, 96%, to calculate the true positives and true negatives, and then the false positives and negatives by difference. And I've done that in this 2x2 table. When I've done that, I can calculate then the positive predictive value, which ends up being 32%. So if I did not have the result of that flu swab, I would expect that 2 or 3 out of 100 people that would come in with influenza-like symptoms would have flu, but 97 or 98 of them would not. With this positive flu test, there's about a 68% chance that the person doesn't have flu, and about a 32% chance that they do have flu with this result. So this result increased the chance of the person having influenza, but didn't even get it past the point where it's a 50-50 shot. So this is very important when clinicians are trying to decide when to do testing. If something has a very low prevalence, then a lot of times we won't do these tests because, quite honestly, it's less likely to give us useful information. But let's look at January, when let's say the flu prevalence is very high. Let's say it's 40%. And now you take and examine a patient with flu-like symptoms, and the test is negative. I go back and try to figure out what this meaning is. I say, okay, well, 4,000 people don't have flu, 6,000 people don't. I can use my sensitivity and specificity to do my 2x2 table and calculate a negative predictive value. In this case, 84%. So that means that it's 84% likely that this person does not have flu and has some other flu-like illness. So these tests that we can run as physicians are useful, and we try to make judicious use of them and applying them when they're appropriate. Now, one thing I do want to say, especially with the SARS-CoV-2 virus going on, and this is also applicable during flu season, when you look at the prevalence of a disease, how frequently that is occurring, in the case of a pandemic or rapidly changing prevalence, it's very difficult to do and apply these calculations when the prevalence is changing very rapidly. Because if I calculated a prevalence of 40%, I get one answer, but if I used 50%, it would be a different answer. So you have to sort of modulate when you're deciding about whether to use these tests. You have to modulate based on not only the prevalence, but how rapid that prevalence is actually changing. And this is especially true during epidemics or during outbreaks when the prevalence is changing very, very rapidly. Let me give you another application. So let's say, for example, that you have several tests to select from. This is a cardiac troponin. Troponin is a test that's used to look for myocardial damage from, let's say, a heart attack. And if this is present, then it's more likely that that person has had a damage to their cardiac myocytes. And so there are several tests. This is just 3 of them, characterizing them by their sensitivity and specificity. Now, if I look at those tests, and I'm the person that has to make a decision which one I want to order, I want to say, well, how do I intend to use this? Let's say I'm in the emergency room, and I want to exclude a person from having a heart attack when they have chest pain. So if I look at this, I want something that if they actually get a negative result, I want to make sure that that's right. You know, I don't want that to be wrong, because if they're wrong, if that test is wrong and you send them out of the ER, all of a sudden they die of that heart attack or they have damage that's irreversible. So you don't want that. So which do you think it would be? Well, that's right. The Siemens test in this case. So the Siemens test has a very high sensitivity. And remember that if you have a high sensitivity, you have a very low false negative rate. And that means that you can use it to exclude, which is what I have in parentheses at SNOT. High sensitivity is to rule out. So I hope that this is helpful in trying to understand something about how physicians will select tests to make it more or less likely that the person that they're examining has or does not have a disease. We'll talk more detail about how to interpret these things in the next time.